Hello and welcome. I'm your host, Ramesh Kumar, and I'm on a mission to bring value to the healthcare industry through improved transparency. And my goal from this podcast is to give you one aha moment that you can implement in your business, whether you're a TPA, broker, or an employer. In my day job, I run a company called Zaki Point Health that helps self-insured employers and their employees provide transparency, direction, and value by delivering a digital front door for the member that proactively steers them. Please like or share this podcast on your favorite podcasting tool so we can bring together a community of like-minded professionals. This program is brought to you by the Healthcare Administrators Association, HCAA. For over 40 years, HCAA has supported third-party administrators and the self-insured employer industry through educational opportunities from leading industry experts. For information on joining HCAA, please visit our website at hcaa.org. Our new sponsor for the 2024 season is Valence Health. Valence Health is the platform to simplify healthcare, the destination for employers, payers, providers, and members to reduce costs, improve quality, and elevate the healthcare experience. The Valence mindset and culture of innovation combines to create integrated solutions. Valence engages early and often to execute across the entire patient journey, from care navigation and management to payment integrity, plan performance, and provider verification. With a 99% client retention rate, Valence Health elevates the expectations to a new level of efficiency, effectiveness, and transparency where smarter, better, faster healthcare is possible. For more information, visit valencehealth.com. This podcast was recorded live at HCAA Executive Forum in Las Vegas in February. Unfiltered, unmissable, and unleashed. I am super excited to have Fred Goldstein, co-founder and lead host of Population Health Week, a weekly radio show podcast that's syndicated on Healthcare Now radio as well, and the host of ACMP podcast series. This is a two-part podcast recording covering a range of topics like the role of population health data, opportunities to explore in 2024, things like primary care and access, maternity, musculoskeletal, and other specialty programs, how narrow networks, centers of excellence, and other kinds of ACO models are also delivering value, PBM, rebates, transparency, biologics, and really talked a lot about the gene therapies, reinsurance and outcome-based contracts, price transparency, and where that is going, and a whole host of ideas for 2024. Let's dig in. Fred, why should our audience listen to you?
I don't know if they really should or not. I think it's a great question, but my background, just to give you a sense of it, is 40 years ago, the first week of January of this year, I walked into my first hospital as a resident, as a hospital executive. And over the next 40 years, I ran med-surg and then psychiatric hospitals. I then switched the other side of the business and ran an HMO that was a Medicaid health plan. We got a commercial license, a Medicare demo project. We were ranked the highest quality Medicaid health plan in the state of Florida. And in 1997, I founded a chronic care management company called Specialty Disease Management Services. And we developed the first chronic care management program for people with HIV/AIDS, first program for people in Medicaid with schizophrenia. And we ended up doing 10 chronic disease states. We did 10 states Medicaid. We also had commercial clients, City of Tempe, Arizona, Orlando County Libraries, and some others around the country. And then I merged that into a company doing employee health improvement called U.S. Preventive Medicine. And I was the president there, and we had clients in a really unique employee health improvement program. Clients include the state of Nevada. Their state employees were on our product. The Aon employees were on our product. So over the years, I really got to look at healthcare from many different sides. And for about the last 11 years, I've been consulting in population health and really across the spectrum from data and analytics to new apps and devices to pharma, et cetera, and trying to help, in some sense, provide some way to fix healthcare and some ideas around how to fix healthcare. So it's been a fascinating journey. The conference so far has been great. Really enjoyed it. Appreciate the opportunity to get on your show, obviously, Ramesh, and talk about some issues about how maybe self-funded insurers and those that help, self-funded employers and those that help that group are able to provide maybe some unique and better services.
No, fantastic background, and really I've learned a lot in our conversations recently as well. What I thought would be great to focus on today is maybe two parts. First is to look at 2024, as you and I spend a lot of time talking to a lot of experts out there. So looking at 2024, what are some of the big trends that we are seeing that the TPAs, our industry, or self-funded employers should be thinking about, paying attention to? And then as we try to move the conversation to, let's drill down into some of those trends. What are some of the things that are working, and share insights around what sort of data that you're seeing along those trends. And then finish off with, try to leave our audience with one or two steps they can take. So if they are a TPA of a certain size, what are the one or two priorities they should be keeping in mind for 2024? So that's the kind of structure I was thinking. With that, let me just kind of overall kick off. And I know we've talked a little bit about overall risk management, cost containment, and a big example that you talked about was the Rosenhealth hotels, how they have managed costs. Maybe if you could start with that case study a little bit.
Yeah, and I don't know how much the audience knows about Rosen Hotels and Rosen Health in Orlando, Florida, but back in the day, in the 90s, Harry Rosen actually had whoever his insurer was, I don't know if it was the Blues or whatever, came to him and said, oh, by the way, your insurance is going up next year for your hotel, for your employees. And he said, wait a second, what do you mean? I looked at my claims, they're all the same, it looked good, there was nothing going on. And they said, oh, well, we group you with others. And so based on that whole grouping, you're going up. And he got very upset and said, that's fine, I'm just not working with you anymore. And he called his primary care physician and said, hey, I'm going to set up my own self-insured group, my own health plan. Do you want to come in and be the doctor for my employees? And that was the start of Rosen Health. And over the years, he's expanded that out and has about, I think, 6,000 employees at this point and in multiple hotels in Orlando. And he has saved hundreds of millions of dollars compared to others in the hotel industry over the years. And actually, he's talked about how he's used that money to fund nonprofits to help the Orlando community. And what he's done is...
Give some perspective, that's about 30% reduction.
Right.
Compared to the other hotels who have had to go to the BUCAs to get covered.
Right. He's about 30% less in total costs. And as part of that, he's also shown that he has about an 8% turnover rate of his employees versus maybe 60 in the hotel industry. And it's just an incredible work. And they actually have doing some events now and launching this product out to others in a sense. But what he did is he really focused on, one, providing really strong primary care. And they built a near-site clinic for their hotel. And literally, if you're an employee and you need to get a visit to the doctor, the hotel limo or car picks you up and takes you over there. And you're paid for your time. And that's what creates this great employee allegiance to the organization. 90% of their pharmaceuticals are covered at 100%. When you're hospitalized, 2 hospitalizations a year and your total out of pocket is $750. And so he's really been able to show, and they've now expanded the clinic, and they've put in PT and OT, and they've got other lab facilities there and yoga and things. And it's really looked at healthcare in a different sense of how you create a system that can really help employers and those who are self-insured. And the one rule he does have, as he tells people, is I hire 0 smokers. I do not hire a smoker. But his population, when you think about it, and when you think about people who work in hotels, a lot of that population is really low-income individuals. They're very similar to a lot of the work I did in Medicaid or when you're working with those groups. And so they have a lot of issues in terms of access, et cetera, or funding or transportation, even though they may have a job just because of their wages. So the way he set up that system to allow them to access it, his contracts with hospitals are a little bit more unique as well. And at one point, Mr. Rosen actually talked about, I'm going to show the hospital industry I can build one for cheaper and do a better job. And he had all the plans and everything. They decided, look, I'm a little older in my life. I've created this with my hotels and the health system I have. I'm not going to go build a hospital and compete with the Orlando facilities. But it's really amazing what they've done. And it's really by focusing on that upfront stuff and really looking at it. I believe at one time they were also allowing employees to access pharmaceuticals from overseas and things like that as well.
Something like 90% of the drugs were covered
at 100%.
100% of the cost.
Right.
So this is a backdrop to, if you bring innovative solutions, if you think about plan design, if you think about providing that access, you can actually reduce the cost by almost 30% in an industry where MEC plans, that's the equivalent of what other entertainment industry benefits are provided through. And you don't really get much of a coverage there. And when you look at the turnover of the employees, so it's a really important backdrop with what we're going to be talking about now is, well, what are some of the trends that we're seeing coming through from 2023 and into 2024, where you're seeing risks and costs can be managed significantly on a self-funded plan?
Yeah, I think the difficulty we face, and this analogy I was thinking about, is we built a car chassis on square wheels. And so everything above that is just completely messed up and it just doesn't run right. It won't roll down the street appropriately. And those square wheels are fee-for-service medicine. And that's really created, what we tend to do is we layer on these services on top of that, but it's broken to begin with. So you'll get small changes in what you're doing. And I think as we look at this year, I heard earlier we were talking about the weight loss drugs and GLP-1s and their impact. And I think Mercer came out and said something to the effect that they estimate that those drugs alone will have a 50 to 100 basis point impact on total medical costs for organizations this year. And there's a real issue when you think about that. Most companies cover that stuff, and they cover it for not just diabetes, but for obesity, although we've seen some pull it out. I know they talked about earlier in the comments earlier today was something to the effect, when do you think we'll see the long-term impact of reducing diabetes effects in terms of costs? And I'll tell you a story about that that's really fascinating that I realize relates to that. We did a program for persons with schizophrenia back in the day when the brand new, the atypical antipsychotics came out, and they were super expensive. They were the number one drug cost for Medicaid when they came out. And Lilly actually came to us and said, could you develop a program for this? And we did. The state of Colorado took it in and did it. And we got people to take their medications from 23-day fill rates to 29. So they were filling their prescriptions every month instead of losing about 3 months a year. We cut ER visits 54%. We cut hospitalizations 2%. And we still lost money because the cost of the adherence to the new medications was so high that it didn't offset all of the savings from those reductions. And so when you think about something like GLP-1 with diabetes, that diabetes savings could be down the road. And so you've got $1,000 a month hitting on those patients, and it's going to be the individuals who take it, and then there are other issues around that. So I think that's going to be one of the things to really watch. I think North Carolina just said they're not paying for it anymore, and some of the other health plans are looking at it as well. But it's a difficult thing to look at. I don't think we're going to see the huge double healthcare trends we've seen over inflation. It's tended to flatten out. If you look at our percent of GDP over the last 3 years, it's been flat. It hasn't gone above that 19% or so. But it's still going up because our country's growing, and we haven't really put in place things to solve those cost issues around that.
So GLP-1, so they should be careful. And are you saying they should almost pay attention to not include it in the benefits or have a different structure? Because this kind of stuff is happening now and hitting the plans quite a lot.
It's really a difficult area because I think one of the manufacturers has a straight-to-employee model now, straight-to-an-individual model where you can buy these drugs. And obviously, then the individual's going to pay for it. I don't know if they'll run it through their insurance or not. But I think it's something where, when you think about it also, who's now added GLP-1 to their program? Weight Watchers. And so they've sort of recognized that behavioral health approach, that behavioral concept to weight loss isn't quite working. We need something else. But you need to, maybe this is an area where you do some stepping stones or something, or you have some prior auth type of things to try some other things before you go to it. And then the real question becomes, the studies have shown when you're off the product, your weight comes back. So unless you've done some real serious behavior change, you're going to have some issues with that as well.
Yeah. So look at the plan documents and how you are structuring it, ensuring people are taking certain steps before it's approved and things like that. The other big area is the whole centers of excellence, high-performing providers, the value-based care. And this is a very confusing area for many TPAs, for brokers. What are you seeing in the market? Where do you see 2024 to be when it comes to networks, centers of excellence, and high-performing providers?
So this is another area where I don't think we'd put enough focus on it. As my father was a professor of medicine, and I grew up in that, never wanted to be a doctor. The blood just all fall over. And so but I used to go to the ER a lot, and I broke a lot of bones. And I ended up in the ER a lot at UC Davis. And I watched my dad throw doctors out. you're not seeing my son, you're not seeing my son, you're not seeing my son, because he knew who the good doctors were. And I think we tend to assume that it's okay, I can go to this doctor or that doctor, these others, and there is huge variation in quality. And that's why I think these centers of excellence, as Walmart, for those of you who know the Walmart story with back surgeries, they find that they see this huge use of back surgeries, so they tell their employees, here's the deal, your local doctor says you need back surgery, you can get it done there, pay your out-of-pocket, your huge deductible, whatever it is. But if you'll agree to fly to one of these 8 centers of excellence, we'll send your spouse, your partner, your significant other, whoever that might be. We'll pay it 100%. They'll take a look at you. If they say you need surgery, you can get it done there for nothing, or you can get it done back at your regular doctor for all this out-of-pocket expenses, thinking, okay, we'll send them to a quality provider. But what stunned them was those centers of excellence sent 42% of them back saying they didn't need back surgery. So what did they do the next year? They mandated it. You can't get back surgery in your local community. You've got to go to a center of excellence if you want them to pay for it. And they're now looking at it for other procedures, heart and things like that, because there really is. And so this idea, originally narrow networks were a way for health plans back in the 90s at least to cut costs. But actually, Walmart pays more for those centers of excellence than the local ones. But they get way better outcomes, and they have fewer complications and people going back and needing other services. And they also only get the ones who need it done. And so I think the concept of centers of excellence is really a good one. And you'll also see things like Surgery Center of Oklahoma, in which they've got bundled pricing, and it's a single price, or Health City Cayman Island that does the same thing. And it's just one line, one price. And when you think about that from an efficiency standpoint, let's say you're a TPA and maybe your pre-auth procedures or things, you don't really have to check the bill. You have to look for that $75 aspirin because it's just a single line bill. The hospital in Health City Cayman Island has 2 billers for their whole facility. You can save on your staffing by doing things like that as well.
And so how can a TPA go down the path of putting these centers of excellence? What are the steps?
I think the first thing any TPA should be doing, no matter what the steps, is understand their data. What have they got? What does their population look like? What are the areas that seem to be a little bit fraught with issues or potentially out of control? And then you tie that back to what's the skill set you have to impact that issue. So it doesn't do any good to identify an issue that you don't have any skills to fix it. And we call it impactable risk in the population health program. It's something you can impact, and take a look at your population, understand your data, pick a few key areas, and if you're looking at centers of excellence, you can look to what these other companies have done, what the Walmarts have done, or some of the other. There are a couple companies out there that now are set up for self-insured groups to go straight to, and they can contract through them with these centers of excellence. I think Lowe's uses some of those, et cetera, that were developed actually by Tom Emmerich, developed that one company. And he was at Walmart originally and then went out and built a company around setting up these centers of excellence. But I do think it's important because at the end of the day, we all want to be going to the right provider to get the right care and to come up with better health, or at least maintaining our health if we're on some sort of a chronic disease trajectory. And we have to get our employees to understand that just because you like your doctor in their office, that may not be a very good physician, or that might not be the right hospital to go to. And I heard earlier a discussion about, well, we can price them out. We know whose cost is this or that for that procedure. That's great. But if you take a look at just cost or just an alternative payment or a bundle and you don't include quality metrics in it, it's worthless.
Yeah.
You have no idea what you're buying.
Yeah. No, I think I also talking to another TPA around here, where they have focused on just steering members to high-quality places of care. And through that, actually the costs have lowered over a period of time because, as you said, there's fewer readmissions going on. There's an overall, whether it's a high-quality person managing maybe without actually doing the surgery, they're ending up having to take care of that patient in that situation. So really developing this centers of excellence, direct contracts, or other value-based care models where you're using the quality data is a very fundamental thing in building any products now in the market. I think the other thing that I'm seeing is then how do you take all of that and add a layer of care navigation or support to the members, advocacy, different words for the same thing, but how do you support the member and effectively steer them to the right places of care, which might combine some incentives, whether that is a zero deductibles or other forms of incentives, but then actually educating the members. Takes a lot of effort in pulling these types of solutions and products, but I think in 2024, we'll see a lot more of it. We actually have seen another TPA who's done a lot of these pieces and actually grew 60% in 1 year time frame. 60%. That's a pretty good growth rate for a TPA. Granted, they were not that big. So that's a trend that certainly to pay attention to.
And let me add one point to that, because you brought up some great stuff that I think we need to dig in a little bit. This idea of health literacy and getting your employees to understand enough about healthcare to make the right decisions. We've always talked about this issue as let's raise the literacy of our employees and our population and this and that. The reality is we as an industry have to meet the need of the person at where they're at. It's up to us in the industry to provide them with the information versus saying you need to educate yourself and understand this. And I think that's also a fundamental shift that can prove to be really beneficial. If you can provide information to your employees at their level of comprehension so they can make those decisions, those care navigation decisions and decisions about their health, it's a whole lot better than trying to get their health literacy up.
Another area I want to touch, gene therapies, talked a lot about today as well in the industry. What are you seeing there? What trends and what do you...
It's going to be a huge one for self-insured groups. It's even huge for Medicare, as I'll mention in a second. These new gene therapies are coming out. They've talked about them, 2.5 million, 3 million. Think about that. If you're a self-insured group, a $2.5 million product will take your whole 385 employees out for the whole year's health care premium. It's done.
Yeah.
One person. Obviously, you can get reinsurance on this and that. But we're going to see more of these. And it's not like you can say, well, we're not going to provide that. So the federal government is just doing their first program, and they're telling the states to do this as well, is outcomes-based contracts. If the product doesn't work, you're going to refund us this money and whatever that amount might be. And they're now negotiating those kinds of contracts. And most of the larger groups are recognizing that as a way to go about it. The other issue becomes an employer group, less so with self-insured, but if you're switching health plans and the first one got stuck with it, that's problematic. It's going to be interesting to watch what people do with that, but we are going to see a huge increase in the number of gene therapies and other really high-cost approaches that work. And so it's something that, like when the first Hep C drugs came out, nobody really had it built into their actuarial work, and they just were going to wipe out their plans, and they had to figure out how do we roll this thing out. And I think that's something that every TPA should be thinking about now. What are we going to do with them? Is there a way we can ensure that people get them, they work when they get them, and there's even talk about, I heard someone talk about setting up not quite a bank, but a finance arm for gene therapy to underwrite it and pay it over time.
While we're running through these trends, if you have questions, you can certainly write it down and pass it to us. I don't know if there's a microphone in the audience to raise those questions. We'll certainly take questions towards the end. I wanted to move to another few trends that we saw. Direct primary care. It was a big kind of move. And what I wanted to really decipher is the middle market employers did take this on pretty well, on-site clinics in particular. So direct primary care, on-site clinics, I saw some good statistics there. Near-site clinics, what has been the trend there? What are you seeing on direct primary care, and what do you anticipate happening in 2024?
I think at the end of the day, primary care is the linchpin for being successful if you want to manage healthcare quality and costs. And if you can set up, particularly we've seen it with globally capitated primary care providers, and we have a large number of those groups. Humana's got the groups for their Medicare Advantage with Conviva. You've got One Medical and Iora and ChenMed and the rest of them. We're seeing it more in the Medicare space, but clearly a good primary care practice can be very effective. On-site tends to be better. The larger groups like a Rosen can show that. Near-site oftentimes ends up like, well, I can go there, or I'll go to my doctor. I still got to go somewhere. And so bringing in some telehealth and things like that can help with that. But I do think this concept of getting high-quality primary care providers, providing them with a global capitation if they'll take it, and having them become responsible for the care, you're seeing much more and more of it. And I'll be honest with you, we all know the 85% medical loss ratio rule. You got to spend 85 cents of every dollar for insurance product, et cetera. And these globally capitated primary care providers in Medicare are running about a 65% medical loss ratio. They're taking the waste out and the fraud out, et cetera, and they're keeping that margin. So if you can come up with a way to then possibly share that kind of a margin, and I would hope that a TPA would ultimately be able to say, you know what, our network is so high quality and so good that it's cheaper for you to use us, and we're just growing because we've got the most high quality, preventive, cheapest network out there. And I think that's going to be the play when somebody pulls that off, because we keep talking about we're going to drop costs, and very few people really do.
So let me kind of press a little bit on this direct primary care. Obviously, it's very hard for if you're a smaller self-funded employer and if you have employee base spread out. What can that type of employer do, or a TPA who's serving that market? How can we really bring this down to that type of employer and through the TPAs?
Yeah, one is obviously the TPA, you're aggregating groups. So you're creating a larger market, even though you may have a bunch of small employers. And then the question becomes, I've heard statistics that up to 60% of primary care can be done via telehealth. Well, if you think about that, the reason it doesn't really happen today is the primary care doctor's already got the office space. They already have the parking lot. They already have 3 MAs. But if you take 60% of that business and you could move it to telehealth, it's a smaller building, it's less staff, it's a smaller parking lot, and suddenly you've created huge efficiencies. But we're stuck today with these built systems, whether it's a built hospital that we're trying to move people to hospital at home, or it's a built primary care network. But I think using telehealth has incredible possibilities. We're seeing it in the mental health space now, which is another area that needs an incredible amount of focus. And we're seeing it in many other places. And now we're seeing this idea of everyone's really concerned. We're losing rural hospitals. But in Mississippi, they use telehealth. They got tele-ICU. They got telemental health. All these telehealth services, and it's not just the University of Mississippi doing that, but others around the country are taking telehealth and taking the expertise at a larger facility and being able to distribute that expertise to providers through telehealth.
And so telehealth, obviously, it's got its own problems. And I think one of the areas 2024 has to show some results around is better engagement. Models where engagement is kind of promoted and almost as part of the model rather than few people using it and then still having a PEPM model. Are you seeing any good models, good success models with telemedicine, telehealth?
It depends how it's presented to the employees. It really does. And you're right, engagement, if data is the underlying river that flows through creating health in a population and understanding the population, engagement is the holy grail. How do you get people to engage, to do the various things, to use telehealth, et cetera? And I think in this case, it's like all the others. I turn to behavioral economics and say, how can I incentivize an individual through these various behavioral economic approaches to get them to use telehealth or access mental health service or go to these providers? And we're seeing much more efforts to use behavioral economics in our programs, and I think that's what people should be looking at, is understand what those various theories are around it and then implement those in a way that incentivizes employees to make the right decision. And ultimately, once they get going, just like anything, if you start something up and you start up that exercise and things, once you get past a certain point, it just becomes part of what you do. And it's the same thing you look for in healthcare.
So kind of promoting it more proactively, incentivizing it. Perhaps even some of the concepts I'm seeing are, if you create an on-site clinic, effectively it could be a room with telehealth kind of gadgets and stuff. Right. Also mentioning that.
Put something that gives a little room that gives people access to the telehealth services at your employee, at your place of work, and let them use that as a way. And obviously you want to keep things confidential and stuff like that, but you can set those things up and get access for your employees right there so they don't have to leave.
Yeah.
Thank you for joining for part 1. Please stay tuned for part 2, releasing very soon.
And I would like to thank Valence Health, our sponsor of this show. Please join us again for another podcast in the series brought to you by HCAA's Voices of Self-Funding. Please like and share so we can build a community of like-minded people. And tell us about topics that we should bring to you next. Please watch your email for updates and upcoming guests. I'm your host, Ramesh Kumar of Saki Point Health.